So with that, I want to turn over the podium to Andy Oxenham, who's agreed to moderate this, and he can introduce the topic and the speakers. So thanks, Andy.
All right, thanks, Malcolm, and thanks to everyone for coming, and especially thanks to our great set of speakers, who I will introduce right away. So hopefully you can now see my slide.
Looks good.
Yep, great. Okay, so the basic question is, how should we measure cochlear synaptopathy in humans? We have, as mentioned, great speaker lineup. Chris Plack from University of Manchester and Lancaster, and Magda Wojcik here from the University of Minnesota, Enrique Lopez Poveda from the University of Salamanca, and Sarah Verhult from Ghent University, all leading experts in the field, coming from very different perspectives. So I think that should set us up for a very interesting discussion. So to set up the topic, this idea of cochlear synaptopathy is still relatively new. I think the whole field, I think it's fair to say, was kicked off by a paper by Kujawa and Lieberman back in 2009, which showed that exposing mice to high noise levels that was sufficient to produce temporary threshold shift resulted in a severe permanent loss of synaptic connections between the inner hair cells and the cochlear, in the cochlear and the auditory nerve. And you can kind of see that here, that one day after exposure, a lot of these synapses, which are these little red dots here, are pretty much gone in the exposed animals. That was also reflected in reduced auditory brainstem response amplitudes at moderate and high levels. You can see that here. The control is the green, and even 8 weeks later, these thresholds haven't recovered back. Oh, sorry, the responses haven't recovered to where they were. They've recovered somewhat, but nowhere near where they were before. Despite that, the cochlear health, as measured using distortion product otoacoustic emissions, pretty much recovered fully. Basically, this is the baseline here at 0. And after eight weeks, you're basically back to baseline after an initial loss, which would reflect the temporary threshold shift. And that's true not only for cochlear responses by the otoacoustic emissions, but also for ABR thresholds. They seem to recover pretty much back to normal. So we're talking about a suprathreshold deficit. And since then, the big question has been, well, there's been a number of questions, but since then, a lot of work has confirmed the findings. There are species differences. And because of these species differences, what makes it really hard is that it's not possible to confirm the status in living humans, and so we have a lack of a gold standard in humans, which makes definitive conclusions difficult in terms of whether synaptopathy exists and what the consequences are. So the critical questions I hope we'll address today, first of all, are: is cochlear synaptopathy prevalent in humans? If it is it due mostly to noise exposure or aging, or a combination of both? What are the perceptual consequences in terms of everyday communication? In terms of diagnosis, how can we measure it reliably, ideally within a clinical setting? And perhaps importantly also, how can we treat it or compensate it if we are able to diagnose it and identify it? So that's the basic setup. And so I'm going to stop sharing my screen and give the floor to our presenters, starting with Chris Plack.
You're muted, Chris.
Okay, is that good for everyone?
Perfect.
Yeah, great. So yeah, so that was a really nice introduction, Andrew. Thank you very much. So the as Andrew mentioned, I'll just give this little sort of cartoon of what we think is going on here. So cochlear synaptopathy, you have inner hair cells. They're connected by synapses to several auditory nerve fibers, maybe between 10 and 20 auditory nerve fibers. Noise exposure and aging are thought to cause a loss of these connections, and then over a number of years, the nerve fibers will degenerate. But of course, once the synapses have been lost, the neurons are disconnected, then the neurons are functionally dead. So, as Andrew mentioned, we can't ethically, at least not before they're dead, and so we have to explore ways in which we might be able to measure cochlear synaptopathy using non-invasive techniques. And based on the mouse study of Kajarov and Lieberman that Andrew mentioned, the auditory brainstem response was originally the go-to measure of this. So the first wave of the auditory brainstem response, which is an electrophysiological measure, you just present a click or a short tone burst, and you measure the electric potential, record the electric potentials from the scalp produced by neurons at various stages in the auditory system. And wave one of the auditory brainstem response is thought to reflect auditory nerve activity, the distal portion of the auditory nerve. So that is, it's been shown in the mouse model to be seem to be highly correlated with the synaptic survival. So a lot of research groups, including our own, went straight to the auditory brainstem response and looked for changes or differences in wave one amplitude due to things like noise exposure or tinnitus. And I have to say the overall results, though there were some positive findings, were fairly mixed. And there's some doubt about whether wave one is perhaps the optimum measure of activity in the nerve fibers, these low spontaneous rate fibers that some people think are primarily involved in cochlear synaptopathy, although there is some debate about that, which I might return to. Further up the auditory pathway, we have the envelope following response, which is sustained potential produced by the activity of neurons in the brainstem. You often present a modulated stimulus, and this is taken from one of Sarah Verhulst's papers from her group, just showing the response. It's not meant to illustrate very much else, but she's done some, this is based on modeling, I think, this particular figure, but this basically shows that synaptopathy is thought to particularly affect this response. And she's, she'll tell you more about it, I'm sure, but designed stimuli that particularly target these groups of nerve fibers. Another one which has attracted a lot of attention recently, Magda Wojcik has used this technique, and James Shihorn and colleagues, is a middle ear muscle reflex. And this is a reflex contraction of the stapedius muscle that you can measure using tympanometry. And the reason, one of the reasons why this attracts attention, first of all, in mice, Michel Valero has shown that this is very strongly related to synapse survival in mice. It seems to be a very, very good indicator of synaptic health. So that's one thing. And it's also thought to be driven by these fibers, these low spontaneous rate fibers that are thought to be involved in synaptopathy. So other people might disagree, but I think, you know, overall, these are the sort of three main techniques. Auditory brainstem response, wave 5 as well, has been used by some groups. And then I've lumped all these together. There's potentially behavioral measures we can use, and this is just from one of our papers. As some of you may know, you know, we've had very little success in finding synaptopathy. Evidence of synaptopathy due to noise exposure, and this is just an example of one of our failures using various things like frequency discrimination, interoral phase discrimination, and the like. Okay, so I'm just going to give a sort of brief overview of what I think the challenges are in measuring synaptopathy in humans, and also potentially some of the opportunities we might have. So challenges, as Andrew mentioned, there's a lack of a gold standard measure of synaptopathy in humans. So if we have a technique that we think might be able to measure synaptopathy, we don't have anything that we can easily relate it to in humans. We have to rely primarily on animal data to see whether that particular technique relates to synaptic survival in the animal model. So that is a huge problem. Another problem is that there's a very large inter-individual variability of measures. And probably a lot of that, you might sort of say, okay, well, maybe this is because people vary in the number of synapses they have. But I think it's probably for the most part unrelated to synaptopathy. And in fact, there's a lot of other things that might affect these measures. I'm not going to drill down and consider each measure in turn, but several factors might affect some of these measures. First of all, you have hair cell loss and dysfunction. That includes subclinical loss. We know that pure-tone audiometry is fairly insensitive. The audiogram is fairly insensitive to hair cell dysfunction, either inner or outer hair cells. So it doesn't really help to control for audiometric thresholds, because you could still get a loss of in hair cells and outer hair cells that isn't picked up. You also have neural loss dysfunction, aside from cochlear synaptopathy, perhaps in the periphery, but also in the central nervous system. And then you have anatomical differences that can have big effects on evoked potentials. The other problem, the lowest R hypothesis, which I mentioned, is that the high threshold, low spontaneous rate fibers were thought originally to be most effective, and that's by synaptopathy. That seems to be true in the guinea pig model. In the mouse model, Sivakar and Lieberman recently showed that might not be the case, and there's some doubt in humans about whether there is this clear distinction. There's some data from Phil Joris's lab that suggests spontaneous rate and threshold don't group together in the same way as they do in animals. So the idea of the low SR hypothesis is that the high threshold fibers are ones that affect it. You expect things to be worse at high levels. It gives you a nice sort of differential measure of synaptopathy by looking at sort of growth rates or effects that happen at high levels rather than low levels. But this is now casting a little bit of doubt, which of course creates problems to tease apart the effects of synaptopathy from, say, hair cell loss or other neural dysfunction. So just quickly, the opportunities, as I mentioned, differential measures. Can we control for some of these confounds, these inter-individual variability, by using these differential measures that have one measure that isn't affected by synaptopathy and another measure that is? And so things like the summating potential, action potential ratio, Stefan Maison's been pursuing that one. We have ABR growth, so you expect, as I say, if it's low SR hypothesis is true, you expect things to be affected at high levels. And then you have various measures related to the envelope following response. So it might be possible to control some of these confounds. There's also potential for computer modeling that I know Sarah's done a lot of to guide the development of these tests. And it also, computer modeling provides a bridge between animal and human studies, which I think is very valuable. And the good news is that although there's large between individual variability, these measures are so excellent, really, retest reliability. So if you test the same person on two separate occasions, you tend to get very similar results, which means that some of these measures, while they might not be very good for diagnosis or cross-section, diagnosing someone if they just come in and to the clinic and say, have you got synaptopathy or not? Some of them might not be very useful for that, but they might be useful for monitoring healthcare over time. So look at changes. And these are just some data that Hannah Guest collected in our lab, which shows that both wave 1 and the middle ear muscle reflex show excellent retest reliability. So the first session and the second session show very similar answers. And I think I've exceeded my 5 minutes, so I'm going to shut up there and move on to the next speaker.
Magda?
Can you see it?
Yeah.
Okay.
Yeah, let's do it.
All right. So I'll just jump in. So Chris was talking about the great inter-individual variability, and I'll show you some data that speaks to that. So yes, the big problem is that we don't have this gold standard, and there have been some kind of tests that here and there showed significant results, and they were consistent with what we see in animal studies. But when we and other groups tried to find correlations or other measures that would go along with them, that should be also affected by cochlear synaptopathy, we usually fail to show any kind of relationships. And that happened with our study that I'll talk about here. So we kind of took a two-pronged approach, and the two prongs meaning we tested two groups of subjects that we thought would be of risk to of synaptopathy, at risk of synaptopathy. And one was the group with tinnitus. Those were people who had normal or very close to normal hearing thresholds of all ages, and they had tinnitus. So one way to explain their tinnitus, the idea was that perhaps their tinnitus was a result of deprivation of the peripheral input due to cochlear synaptopathy. And then in another kind of line of study, we tested people, used those measures as a function of age, because we know from the temporal bone study by Wu et al. That I cite here, that cochlear synaptopathy seems to be increasing with aging. So we ran in this study with aging. And we didn't have really very old participants. Our groups were between 20 and 66 years old. And we collected a bunch of measures, and we obviously took their audiograms. And first thing I want to mention is that it's very hard to find over even that range people who have identical thresholds or very close. Younger are always better in terms of audiometric thresholds, even if it's just 5 or 10 dB. But there is a greater, obviously, departure of thresholds as we go up in frequency. So we kind of titrated our stimuli to hit this region where hearing thresholds were not as divergent, but also compare some measures at least between, let's say, 4 kilohertz and 2 kilohertz, where thresholds were more divergent versus less divergent. And we collected a bunch of behavioral measures that we thought should show some deficits in that would be consistent with cochlear synaptopathy, and that was AM detection thresholds. And we used only high rates because the only study that showed significant effect, the animal study of AM processing, and AM processing was a study by Sachin, I forgot, et al., who showed that EFRs actually are reduced in mice with cochlear synaptopathy, but only at frequencies of about modulation frequencies 5 hertz and above, 500 hertz, sorry, and above. We measured gap detection, envelope ITD thresholds. We measured envelope following responses, all measures similar to what Chris Plack did in his studies, when they also failed to find really any significant effects that would be consistent with cochlear synaptopathy. And finally, we tried to relate everything to speech recognition, and we had speech, and the outcome measure was spatial risk from masking, with the idea that people who have worse temporal, some kind of temporal deficits and temporal processing, they will be able to less use the spatial segregation between the stimuli. So we found no really significant correlations, but we did find that spatial risk of masking was related to, was correlated with age, significantly so. But then here's the kind of the matrix that show the correlations, and that's where things were kind of depressing, showed a very depressing picture. So within each measure, and there are AMTD, AM detection thresholds, and we have envelope ITD, EFRs, and spatial risk from masking. We had one cognitive test as well for processing speed. But within each task, thresholds were correlated, or results were correlated for across different parameters used for a given task. But across tasks, there was no correlation whatsoever. And I want to point out that all of those tasks have been used in the past and are often used to address the because they are thought to be associated with temporal envelope processing. So you would think that if there is a degradation, then correlations between tests should show, but we didn't see any correlations whatsoever. So we also looked at, as I said, tinnitus group and again, the non-tinnitus as a function of age. And for tinnitus versus non-tinnitus, we replicated our original results in that people with tinnitus had lower middle ear muscle reflex and slower slope than, or shallower slope than those with tinnitus. And when we just considered people without tinnitus, we found age effects on middle ear muscle reflex. And even though young listeners, there were a lot of young listeners who showed pretty weak middle ear muscle reflex. So we also used a different measure, which was based on ABR wave 1 only, and we took a different approach than most studies. So instead of taking a ratio of ABR wave 1 to 5, we took ABR wave 1 ratio for 2 different traits. And we found this effect of tinnitus that was significant, where people with tinnitus had a greater drop between ABR wave 1 for higher versus lower rate than people without tinnitus. And then we again saw correlation for specialists from masking with age. That was significant for non-tinnitus participants, but not for participants with tinnitus. This could potentially be interpreted as people who are even younger but had tinnitus already had some deficits, and they did not show significant effect of age. But that's, of course, would require validation by having another measure that would go along with it, that would be representative of synaptopathy. The interesting thing was that when we correlated the specialists from masking with middle ear muscle strength, we did find significant correlation. And those 2 graphs are for conditions where all speakers target and mask are at the same pitch and different pitches. In both cases, we found significant correlations. And it wasn't just by association that the reflex was activated by speech. So because the speech was presented at a level that does not really make the speech a strong activator of the reflex. So one way to explain those results would be that there is a common underlying mechanism that affects both. But again, the lack of the gold standard and the lack of kind of correlations between measures make those results hard to interpret in terms of synaptopathy. So that's all I have, and I'll stop sharing.
Enrique?
Okay. Can you see the presentation?
Coming up, yep.
Coming up, okay.
Looks good.
Okay. So I'm about to say almost the same thing as, Magda and Chris. I'd like to start by saying that to me, there's no question that synaptopathy actually happens in humans, at least related with age. I mean, not so clearly related with noise exposure, but definitely related with age. And this is just one paper, that shows a decrease in spiral ganglion cell count with increasing age based on the analysis of temporal bones. So to me, there's no question of that. Now, as to the question of how to measure it, we just basically followed, the studies in mice. We've been using wave 1, the ABR wave 1 as our metric, but instead of using the amplitude for any particular stimulus level, we've been using the slope, so a differential measure. And we were careful to use the metric in the appropriate units. I mean, if you plot ABR wave 1 amplitude on a log scale, there is no change in the slope over the range of levels, that we normally use to measure ABR wave 1 in humans. So instead of using a logarithmic scale, we're actually using the slope in microvolts per dB as our metric for synaptopathy. And this is just to give you an idea. This would be the slope in an older woman is 55 years old. I mean, older, not so old, but 55 years old. And this would be the slope in a younger woman, age 16 years. You can see there is a clear difference in slope, which again is the metric we've been using. Whether or not this is appropriate, we can discuss later. The slope may be confounded by other factors in addition to synaptopathy. Now, I mean, we've been trying to see whether this metric of synaptopathy is correlated with age-related hearing deficits, and we actually see no correlation. So, for example, we see that the slope correlates with age, as you would expect. So there is indication of synaptopathy in our older listeners. And we also see that the older listeners show a slightly worse speech and noise intelligibility. So, for example, the speech reception thresholds are slightly higher, but significantly higher, particularly in fluctuating maskers. So the same people who had synaptopathy also have problems in noise, or more problems in noise, but we don't see correlations between speech reception thresholds and wave 1 slope. So, which, suggests that maybe synaptopathy happens, but it has very little significant impact on perception. Of course, we are conscious that the synaptopathy metric may not be sensitive enough. It could be confounded, for example, by strial degeneration if there is a reduction of the endocochlear potential that happens with age, for example, that might change the wave 1 slope in a similar way as synaptopathy does. It is also possible that synaptopathy happens, but it has to be quite strong, before it has any impact on perception. And this figure here is data from our study, which is now in revision. We were simulating how much synaptopathy is necessary for it to have any impact on speech and noise intelligibility. This is based on a computational model. And we only see significant changes in speech reception thresholds when we lose 90% or 95% of the fibers, yeah? So maybe the older people have synaptopathy, which is measurable in wave 1, but it's not enough to have an impact on perception.
Enrique, is that in clean or noise?
This is in noise. This is in noise, DBSNR, yeah? This is in noise. So we're actually now looking for alternative explanations for the age-related hearing deficits beyond synaptopathy. We're looking at other things that I don't have the time to explain. But the same pattern of data that I've just shown you for speech and noise intelligibility, we also see for gap detection threshold, for frequency modulation detection thresholds, and also for speech and noise intelligibility in other type of maskers. So my conclusions are that to me there is no question synaptopathy happens, at least with age. There's no question that degrades the neural encoding of sound, particularly in noise, and the impact of synaptopathy could be greater in noise, but we see no evidence of age-related hearing deficits related to synaptopathy. And instead, we think that the deficits might be caused by something else. That's my story for today.
Thanks, Enrique. Good, great. Let's move on to Sarah.
Yes, let me try this. Select the window, this one, allow, and then, do you see the slides?
Yep, perfect.
Yeah.
All right. Yeah, so to follow up on what was said, because I think there's many things said, so I can be rather short. I think in one way, for me, the improved diagnostics will lead to a better understanding of the functional consequences. And I think we're getting there, but I think also that, we need to be careful comparing apples and oranges. A measure of synaptopathy might be going through the whole dynamic range of nerve fibers that you have available, whereas sound perception experiments or any other basic or more cognitive test, of course, has many more factors in it. But to show you a little bit about this interdisciplinariness first, I mean, using model-based approaches, we've been thinking about what would be, let's say, a good, strong marker of synaptopathy in humans. So for that, we started with the EFR responses, and then Vyacheslav started simulating some alternative measures in our auditory models. And so we came up with this RAM stimulus instead of the SAM stimulus, meaning that it's rectangularly amplitude modulated. The reason why we do this is because this is really going through the whole dynamic range of nerve fibers, going from a 0 to 1. So it's actually a very good way to go through this whole dynamic range of fibers, and at the same time sort of avoid effects that outer hair cell loss might have on the response. So this was, of course, a model-based approach, but then together with Ken Henry, we actually tried to, verify that what we were simulating and also measuring actually made sense as a good marker for synaptopathy. So here you see in the budgerigar, where we can also measure the EFR to SAM and RAM stimuli, that you can see that for the same animal, for this RAM, you have a much greater response, and that when canic acid is administered and a synaptopathy is actually there, that both markers are reduced. But of course, the reduction is the highest in the RAM stimulus. So here's a way in which the models can help us together with human data, animal data, to sort of bring this story better. If you look at all the budgerigars, I mean, yeah, the same trend applies. Of course, we have higher RAM than SAM EFRs, and so a much bigger dynamic range. And I think this is important both for sort of the retest reliability of the measures, and also, if you want to quantify synaptopathy, if you have it already much bigger to begin with the response, then of course you can have much more steps of individual differences. And I think this is a crucial aspect when we start relating these metrics to what is sound perception. So these were budgerigars, but this is our human data that goes with that. So as temporal bone data shows, and as our marker shows, when you are older, you do get, especially for the RAM response, you get a lower amplitude. So this is all consistent with the idea that there is also age-related synaptopathy in humans, and that we could measure it using this RAM EFR responses. So from good markers, I think we need to then start asking the question, how does it relate to sound perception? And there are many metrics possible, but I only show you one example here of a recent study where we had sort of relatively normal hearing participants of various ages, and we looked at how this marker now relates to speech reception thresholds in the same listeners. Here the task is very simple. It's this 5-word sentence test in noise. So we are assuming that the cognitive measures don't have a lot to do with it. And you see that the different colors are for the different age groups. So if you just look for a minute at the x-axis first, you can see, aside from this one outlier, that most of the red colored dots are in fact also in the beginning of the curve. So the age-related aspect of synaptopathy is clearly also seen there, but you can see a lot of individual differences. So also within an age group, there can be various degrees of synaptopathy in people, and that makes also sense because their lifetime noise exposure may have been different. So even though you can see big age trends when you take old versus young, when you start plotting everything across age groups, you see quite some variability there. Huh? And then the marker with speech reception thresholds here, if you look at the correction for PTA, the RAM EFR still has a significant contributor to the end result of speech intelligibility. But as this model also shows, it might not be the only thing that determines your speech intelligibility. So that's where, we have to really look at good markers and good diagnostic markers, and then how do they contribute to the perception. And I'm not sure that there is a one-on-one marker at this moment that gives you a predictor of a complex sound perception element, but it's definitely there. And the way that I want to finish with and want to end with is also, if we start treating synaptopathy in people, which is at the moment not possible right now. But if it is, then we might see also that there is an improvement in those tasks. And I think this is what is going to give us the strongest evidence that, in fact, there is a functional deficit, and that when you treat it, that there is an improvement. But we're not there yet. More experiments need to come for this. But I think that's at least the way that we're thinking about it. So if you treat these people not for their PTA, but you treat them for their synaptopathy, will their sound perception, in fact, become better than it was before? Time will tell, I guess. So here's how I end.
Well, thank you, Sarah. That was really, really interesting new data, and great to see some promising new approaches. Anyone in the audience, feel free to put some questions up in the chat or some discussion points. There have been a few already. Manita made a good point, following on from some comments by Casey about the influence of cognitive measures. Manita thought we shouldn't really do these kind of behavioral measures without some sort of measure of cognitive function, at least as a covariate in these kind of studies. I think, yeah, that makes a lot of sense. Well, one question, Chris, raise your hand.
Yeah, I think I agree with that, but I guess a caveat is if you're using a differential behavioral measure, you can potentially control for that. So if you have two different conditions, one is affected by synaptopathy, one isn't, but they're both equally affected by the cognitive measures.
Yeah.
So I think there are ways around it, but I agree it's always good to make cognition.
Enrique?
Yes, I just wanted to say that this question, by Monita actually relates very closely to our latest study, where we actually included, our latest study was on gap detection, frequency modulation, speech and noise for people of different ages, all of them with normal cognitive function according to the Montreal Cognitive Assessment. But we did measure something very simple like the Stroop test, color and word test, and we saw no correlation between performance in those auditory tasks and our metric of synaptopathy, which again is wave one slope. But we did see a strong correlation with the performance in the Stroop test, as if the older people were less able to suppress, to inhibit the distractors. In almost virtually every auditory task that we use, there is a distractor, whether it is background noise, whether it is masking noise for spectral splatter, whatever. So it looks like, the older people with normal hearing have more trouble inhibiting distractors than, the impact of synaptopathy itself. So I do agree with Monita's comment.
Malcolm, I saw your hand raised.
Go ahead, Magda.
Oh, okay. I want to mention we also measured trail making test, 2 versions, and we saw that indexes processing speed and executive function, and we saw that older people did worse on that test, but there was no correlation with any of the tasks that we were running. So,
Malcolm,
So I'm going to jump in as my role as organizer. Everybody else knows a lot more about this than I do, but I'm surprised how hard it is to find measures that show some effects. I was really struck by Enrique's comment that 90 to 95% loss of the synapses to see changes in the speech and noise performance. And yet my audiology friends say there's this humongous problem with hidden loss of hearing and poor performance on things like speech and noise tests that aren't explained by thresholds. So I guess I don't know whether the question is we really having a clue about how to see the effect, or whether there's something other than synaptopathy that's affecting, hidden loss of hearing.
Sarah?
I don't know. Yeah, if I might. So what I think is interesting to know, if you look at these temporal bone data, that actually almost 50% of the fibers are lost at the age of 45. So, I mean, that might also be the age where people start perceiving problems. So I follow Enrique to some degree that you might need a certain degree of loss. There's other studies showing that, with speech intelligibility data from Naomi Bramall, as well. You might need a considerable loss before you get problems, but the question is still, does that need to be 90% or is that maybe 50%? It's maybe somewhere in between there, right?
I mean, speech and noise is our most valuable perceptual ability. And if a factor of 2 cut in the number of synapses doesn't affect speech and noise, are we looking at the right thing?
Well, a factor of 2, just based on sort of very theoretical arguments, a factor of 2 loss of connections might predict something like a 1.5 dB change. And individually, that's enough. That'll make a difference, but it's hard to establish that in population where there's so much variance due to other factors. A 1.5 dB change may not be measurable. It's basically swamped by other variants. But as an individual, you might well notice that things are worse now that you're going to the bar at the age 50 as opposed to the way they were when you were 25.
Yeah.
And there are
Doug
clearly,
has a sorry. Go on, Magda. Let me read Doug's comment.
there are clearly other factors that are more central that can affect speech and noise performance or speech and noisy situations. So it doesn't have to be synaptopathy, but it was just very exciting when the first study appeared, because we thought, well, there may be this peripheral component that will explain at least some of the variance, and yet we have trouble really explaining any variance in terms of the measures that we can collect in humans. So.
And it's also the cascade. Oh, sorry.
Go on, Sarah.
Yeah, but it's also the cascade of events happening after this synaptopathy, right? So if there is some connection to middle ear muscle reflexes to sort of operating point processing of speech and noise, then, the synaptopathy in itself might not be the worst problem, but it might be what it leads in. And I think also there we need more data of how this progression really works, because if one thing is clear, it is the first sign of permanent hearing damage. So at least it's worthwhile diagnosing it to then see how it progresses and interacts with other mechanisms in the midbrain.
But Doug had an interesting comment. I don't know, Doug, do you want to say that, or shall I just read it out for you?
Well, I can try. Can you hear me?
Yep.
Well, some of you, or many of you, may know that we've done population level tests on maybe 10,000 U.S. service members with normal hearing and not really serious hearing problems. Ken Grant, who might be on the call, he just published a paper showing that people who were blast exposed in the military have substantially worse hearing complaints and also worse binaural detection, apparently, or at least NOS5 threshold detection than those that aren't blast exposed. And that's backed up by every study that we've done. And in fact, it's not just hearing complaints, it's also an NOS5 detection, but we also see longer response times for speech and noise testing, not necessarily lower performance, but longer response times. I think the key thing maybe about this study that's different than the other ones is we asked people whether they were experiencing symptoms of changes in hearing after exposure to noise, as opposed to what a lot of studies have done, which is just sort of try to catalog the overall lifetime exposure to noise without regard to whether people have had symptoms. So that may be one of the key components here. But of course, the other key component could be something related to the noise exposures that we have that are unique in the military, because they do obviously have a lot of noise exposure. I think it may be the combination of having that susceptibility, which our data sort of indicates may be noticeable in the real world with lower noise exposures, plus these high-level blast exposures that you get in the military causes trouble. So one particular data point that I think is relevant to that is if we look at people who are new to the military, have less than 1 year of service, we find that this question about whether or not they notice hearing changes doesn't really correlate with their hearing complaints. But if we look at people who've been in the military for 3 years or longer and have these complaints, then they all start to show hearing problems and some of the functional deficits. So I think this does seem like in all ways to meet sort of the criteria what Kujawa and Lieberman were talking about. We just don't know whether or not these people are floating around in the civilian world or not. But we're very interested in ways to sort of analyze what these people's hearing looks like and try to figure out on a more mechanistic level what exactly is the nature of their deficit.
Yeah. Gabriel Gomez raised an interesting point. Something to think about longer term is that even if we were able to diagnose synaptopathy and had a beautiful clinical measure, what would we do about it? Would we be limited to future neurotrophic type approaches, like pills or injections, or are there some signal processing type approaches that might help things differently from the way current hearing aids do?
Sarah?
Yeah, I mean, I was on the one hand, and I wanted to reply that to Doug also earlier. I think it's important to start monitoring people with a good metric, whichever one it is, over time in the military or before, after treatment. Then you might think of new neurotrophic approaches where the marker should show that the treatment works. But aside from that, and until these treatments become available, I do think that with signal processing we can also make some algorithms that are synaptopathy targeted. I mean, in our lab, we use our model-based approach for this in a closed loop system to come up with some algorithms that don't really apply gain, but try to steer the remaining auditory nerve fibers as efficiently as possible. Let's put it this way, because you must think that you can't, if you've lost 50% of your fibers, they're gone. So the only thing I think you can do with signal processing is to try to steer what is left as efficiently as possible. And I think Enrique has also some thoughts on that, probably from his lab.
Yeah, exactly. I think that's a very good question. What could we do about it if it happens? Yeah. Well, based on our modeling work, we have a couple of studies, that suggest that probably amplification helps, because if you have fewer fibers, by amplifying the sound, you maximize the chances that they will fire, and therefore that they will encode. I mean, you have more spikes in the auditory nerve to encode the acoustic information at higher levels than at lower levels, because the probability of firing, of course, is greater at higher levels. So amplification could help. Of course, we know that if you bring the fibers into saturation, then the envelopes could be less well encoded. But of course, this is at a single unit, in a single unit condition. At a population level, then maybe bringing the level up, amplification might help also encoding the envelope. So I think amplification would be, could be helpful, not for the reasons that we might think, not only to bring up audibility, but also to help encode envelopes and the fine structure of sounds as well. So if you increase anything that increases the probability of spiking or the number of fibers that spike, might be helpful.
Magda, you got a hand raised.
Enrique, are you talking about speech in quiet and those measures in quiet? Because in quiet, people, even older people, don't really experience many difficulties with. So I don't know how we would measure that.
I think I'm talking about everything. I mean, this is just information theory. I mean, every spike conveys, one bit of information. If you have fewer spikes or fewer fibers spiking, the auditory nerve conveys less information. If you have more spikes and more fibers spiking, then you convey more information, whether it is in quiet or in noise. It's just that if you have fewer fibers, you have a noisier representation of your stimulus. Or if you have fewer spikes, you have a noisier representation. So your internal noise goes up with synaptopathy, and of course, in a noisy world, the increment in the internal noise makes your performance poor, at least theoretically. Yeah, but then again, you might need to lose a lot of fibers for synaptopathy to have an impact. So in terms of information transmission, you increase the number of fibers, or you increase the probability of firing.
But that would argue that, I mean, I agree with you, Enrique, but that would argue that it should show up really well in speech and noise experiments.
Sorry, can you say that? Yeah.
I mean, I agree completely that information theory is the right way of thinking about this. If you have fewer spikes, then you have, noisier data.
Yeah.
So it seems like speech and noise experiments should be a really, really powerful way of seeing the effect.
Yeah, and I agree with. I mean, any noise, any experiment in noise, should be more affected by synaptopathy. And theoretically speaking, I truly think it does. Yeah, synaptopathy affects performance in noise, but it does to a much less extent than we think. Or to put it in other words, we need a lot of synaptopathy before we see a significant effect.
Or there are other sources of variability that makes it so variable between subjects that we cannot really detect it. So
yes, that true, of course. Or yeah, or maybe we can. I mean, maybe synaptopathy affects performance in a different way. Like, you know, somebody was mentioning fatigue, yeah, or listening effort. Maybe the level of performance is the same with and without synaptopathy, but the effort needed to perform at that equal level is greater with synaptopathy than without it. Yeah. So.
Well, clearly more noise leads to more listening effort.
Yeah.
So I think those are correlated. Matt Fitzgerald, my colleague at Stanford, has speech and noise data on 50,000 patients, and I wish I was more familiar with it, because he's seeing pretty dramatic effects with people, you know, with the same hearing thresholds, seeing, you know, quite different results in speech and noise thresholds.
Yes.
So there's clearly something there.
Mm-hmm. Mm-hmm. Yeah.
But we haven't found any correlations with anything.
Yeah.
Chris, you got your hand raised.
Yeah, I think it's important. I mean, I'll make a couple of points, actually, one of which is that there seems to be some evidence that synaptopathy might be a cause of tinnitus. Of course, tinnitus is a major problem for many people. So aside from speech and noise, you know, doing something about synaptopathy might be useful for tinnitus, possibly hyperacusis as well. The other point I was going to make is that even if we can't do anything about it, it's still being able to measure synaptopathy and getting an early detection of noise-induced damage might be very, very valuable for healthcare monitoring. So I don't think we should, you know, stop just because we don't think we can do anything about it. I think being able to, you know, on an individual basis, prevent someone from getting further damage would be very valuable.
Sarah?
Yeah, I thought what is interesting, and it should go to Magda afterwards because it links, is that if you look at our RAM EFR marker in age-matched tinnitus and non-tinnitus patients, we see, of course, the general age-related effect. But in those age-matched group, there is no tinnitus-specific difference in this RAM EFR, which I think is very interesting in relation to the data that Magda was showing, that maybe tinnitus and synaptopathy, you know, synaptopathy may be there, but how it then generates tinnitus in one person or the other is, to me, at this moment, not clear. And I think for that, I think it's interesting to see what the relationship is between sort of this MEMR data and the EFR data, if both are linked to synaptopathy, right? So Magda, what do you think?
Yeah, no, I agree. I mean, we found this weird effect. I didn't have time to talk about what, but when we were looking at the ABR wave 1 as a function of rate, we found this strong effect of tinnitus, where people with tinnitus would get a greater drop in the ABR wave 1 amplitude with increasing rates. But when we were looking at a function of age, we found no age effects in that same. So yeah, there you go. Another question, another piece of puzzle that we need to, yeah. In regard to, I actually ran, because I was very interested in the stimulus that you are using, because it seemed so promising, and I especially was impressed by you guys' simulations and finding that it can overpass basically the effect of cochlear, any kind of cochlear damage potentially. But you have a lot of harmonics and you sum them to get the total measure of EFR, and that is also affected by the amount of nonlinearity. So in a way, any kind of cochlear nonlinearity would potentially affect whether it's inner hair cell nonlinearity or anything that's happening there. So yeah. What do you think about, in other words, you show those correlations with speech, but when I looked at that, it seemed to me that it was also consistent with the fact that if people had more cochlear nonlinearity, in other words, healthier cochlea, that would also explain that they should do better in speech, if it's peripheral.
Yes. But there, I think we need to make sure that our markers are really only sensitive to the synaptopathy aspect. I think it's one of the most difficult things to achieve. I think we're getting there with the RAM versus SAM. If you look at the SAM EFR, it is really affected by outer hair cell damage, whereas the RAM is much less so affected by it. And so it is a more sensitive metric. So let's imagine that you have that super sensitive metric of synaptopathy, then putting it into like a linear regression model, you can treat it as an independent factor. And then we are again able to separate the sources and see whether treating one thing or the other makes an actual difference. But I think that's what we need to work towards if we want to go beyond in the diagnostic, to really have that sensitive markers that are not influenced by outer hair cell damage.
So it's the top of the hour, and I'm going to put Andrew on the spot and ask him if he wants to say a few words to summarize things before we thank the speakers. So do you have any offhand comments or summary, Andy?
Well, given that it's already 3 minutes past, I think I'll conclude by saying it's clearly complicated. I think what we heard was a great summary of the current state of affairs, that we're not 100% clear how best to measure it, what kind of effects it'll have. But I think Doug made a great point, that there may be just certain types of noise exposure that we haven't been able to pin down yet, that may well have measurable effects. And if we're able to concentrate on those, we may be able to get a handle on this. And Harry made a nice point in the chat to finish up, perhaps, that even if we can't necessarily treat it, just giving patients a diagnosis that helps them understand what they're going through and can often make a big difference to people.
Yes, I think this has been great. I was hoping that I'd have like a silver bullet by the time we finish this hour, but I guess I was too optimistic. We don't have to end right now, but I want to thank. Go ahead. I'm sorry, Magda.
I just said you and all of us. We were hoping to.
This has really been wonderful. We don't have to end right now, but I want to take this opportunity to thank the speakers before people have to start dropping off. This is, in spite of the lack of silver bullet, I think this has been really wonderful to see, and I want to thank Sarah and Magda and Enrique, Chris, and Andrew for doing this. And we'll stick around for a little longer if you have questions or any other comments. So thank you, everybody.
And thanks, Malcolm, for pulling it together. It's been great.
Thank you.
Thank you.
Anybody else have questions from the audience?